Bismillahirrahmanirrahim. Today we discuss disorders of the posterior pituitary gland, and in particular we will discuss the diabetes insipidus. I will need the concentration of my students. We know that the pituitary gland is divided into anterior pituitary gland and posterior pituitary gland. The anterior pituitary gland contains various populations of the trop cells, for example, somatotrop cells, thyrotrop cells, gonadotrop cells, and these hormones from the anterior pituitary gland are secreted in response to various stimulatory and inhibitory factors that are released by the hypothalamus. The two inhibitory factors for the anterior pituitary gland are the growth hormone inhibitory hormone or somatostatin and the dopamine that inhibits the secretion of the prolactin. Now, the releasing stimulatory or inhibitory factors produced in the hypothalamus travel to the anterior pituitary gland in the hypothalamic hypophyseal portal circulation, which is a network of capillaries in which the hypothalamic factors travel in the blood and act on the anterior pituitary gland, releasing hormones. They travel in the blood to their target organs in the body and have their effects. But in the case of posterior pituitary gland, actually the hormones are produced by the hypothalamus. The neurons in the hypothalamus known as the supraoptic nuclei and the paraventricular nuclei, which contain clusters of neurons, they produce the hormones, two major hormones, the antidiuretic hormone and the oxytocin, and these hormones are released by the axon terminals in the posterior pituitary gland, and here simply they are stored, and when signaling occurs these hormones are released. The hypothalamus senses changes in the body, for example, changes in temperature, changes in the osmolality, and accordingly they order the pituitary gland to make secretion of various hormones. As I mentioned that the hormones of the posterior pituitary gland, mainly the antidiuretic hormone vasopressin, as its name indicates, it will cause reabsorption of water from the urine in the kidney and will decrease diuresis. And the second hormone is the oxytocin, also known as the cytocinon, and it has got its action on the pregnant uterus at the time of delivery by stimulating the contraction of the smooth muscles of the uterus, facilitating labor and facilitating the birth of the child. And its second effect is on the mammary glands associated with milk ejection or lactation. So the hormones produced by the hypothalamus are released from the axon terminals and they are simply stored in the posterior pituitary gland. And upon signaling, when these hormones are needed, they are released. The oxytocin has got two actions. During childbirth, it facilitates the rhythmic uterine contractions, and these contractions push the baby and cause facilitation of the childbirth. While its second effect is on the breast mammary glands, where they where it causes milk ejection, particularly when a child sucks the nipple of his mother. The oxytocin is released and it causes milk ejection. We know that the prolactin, which is in normal life inhibited by the dopamine from the hypothalamus, but its secretion is increased in pregnancy and lactation by the feedback inhibition of the dopamine. And the prolactin, along with the other hormones, mainly the progesterone and human placental lactogen, cause the development of the mammary glands of the breast. And then with oxytocin, it causes ejection of milk to be available to the feeding baby. The most important is the antidiuretic hormone. Since oxytocin is needed timely, so it comparatively its clinical importance is less. The antidiuretic hormone or vasopressin has got two actions. It flows in the blood into the kidney, and in the kidney nephron it acts on the cells of the distal convoluted tubules and collecting ducts, distal collecting ducts. And here the antidiuretic hormone facilitates and increases the reabsorption of water from the urine. So in this way it increases the water content of the blood, making the blood isosmolar, while at the same time making the urine hyperosmolar by increasing the solute content and decreasing the water content that is reabsorbed. The second effect of the antidiuretic hormone is causing constriction of the arterioles, and by doing vasoconstriction it increases the blood pressure. The secretion of ADH from the supraoptic and paraventricular nuclei, which are modified glial cells, are pituocytes, where the ADH is synthesized, and the osmoreceptors present in the hypothalamus senses the osmolality of the blood. When the blood is hyperosmolar, by that we mean that the solute or sodium concentration is more. We know that the major solutes in the blood are the sodium, glucose, and others. And the colloidal osmotic pressure of the blood, also known as the oncotic pressure, is mainly made by the presence of the plasma proteins. Additionally, the left atrial distension, which stimulate the stretch receptors and the exercise and some emotional states, also increase the secretion of antidiuretic hormone. Now, the antidiuretic hormone moves in the blood to the kidneys, and here it acts on the distal convoluted tubules and collecting ducts, and from here it will increase the reabsorption of water. And in this way it is adding water to the blood while making the water excretion less in urine. The antidiuretic hormone is a moderate vasoconstrictor, and by narrowing the blood vessels causing vasoconstriction it increases the blood pressure. As I mentioned, the oxytocin has got its action in female, particularly by facilitating the birth of the child, by increasing the contractions of the myometrium or smooth muscles of the uterus, and its second action is contraction of the muscles that surround the lactiferous ducts of the mammary glands by causing milk ejection. So clinically, oxytocin is less important as compared to the ADH, and the major diseases known as the diabetes insipidus and inappropriate secretion of antidiuretic hormone are due to abnormalities of the antidiuretic hormone secretion. Now, before we go to discuss the disorders of the posterior pituitary gland, let us have a brief view of the molarity and molality. Molarity and molality are nearly the same things, but the difference lies in their expression. In osmolarity, osmol 1 milliosmoles is equal to 1 mole is equal to 1000 milliosmoles, and we express the osmolarity and osmolality in terms of milliosmoles. That is, 1 mole is equal to 1000 milliosmoles. If we measure it by the volume of the solution, by that we mean milliosmoles of the solutes per liter of the solution. So here the expression is in the form of volume, and it is known as the osmolarity, and it is the main expression of the solution in the laboratories. While medically we express it in the form of osmolality, and here we express the number of milliosmoles of solutes by weight per kilogram of the solution. The osmolarity and osmolality can be interchanged by calculations, but here we will mainly talk about the osmolality, that is the milliosmoles of the solutes per kilogram of the solution. The normal blood osmolality is 285 to 295 milliosmoles per kilogram. In between 285 and 295 are below 300 milliosmoles per kilogram. While in urine, we express, and the normal osmolality of the urine is 500 to 800 milliosmoles per kilogram. And these measurements are adjusted by the antidiuretic hormone of the posterior pituitary gland that will increase or decrease the reabsorption of water from the urine. In this picture, we can see that this is an hypoosmolar plasma. By that we mean that the solute concentration is less and the water content is more. But here in this picture, we can see that the solute concentration is more, but the water content is less. So this solution is having high osmolality as compared to this solution. And the hypothalamus in the brain senses this osmolality, and then according to the osmolality of the blood, it will cause increase or decrease secretion of ADH and increase or decrease reabsorption of water, and in this way it will adjust the osmolality of the urine, and indirectly by adding water to the blood it will adjust the osmolality of the blood to the level below 300 milligrams, 300 milliosmoles per kilogram in the blood. So by sensing the osmolality, the hypothalamus adjusts the secretion of ADH, which will cause reabsorption of water from the urine, making the urine hyperosmolar and blood hypoosmolar. And in this way, the hypothalamus will maintain the homeostasis. Now, the mechanism here is that suppose the blood is hyperosmolar. By that we mean that the solute concentration, which is mainly made of sodium, glucose and other solutes, it is more than the water content, and the blood is hyperosmolar. It has got increased osmolality. This increased osmolality will stimulate the osmoreceptors in the hypothalamus, and the hypothalamus in response will cause antidiuretic hormone secretion. The antidiuretic hormone will go in blood and it will act on the distal convoluted tubules and collecting ducts in the kidney nephron. And here the specialized cells contain proteins and the name is the aquaporins. These are normally situated in vesicles in the cytoplasm. Under the action of ADH, which has got receptors in these cells, and the binding of the ADH to its receptor, and this ADH receptor complex will cause the aquaporins to move to the luminal surface of the cells. And here they will open the aquaporin channels and will allow the water to enter from the urine into the cells and ultimately into the blood. So by increasing the water content, and increasing more excretion of the solutes, the blood becomes isosmolar, where the solutes and the water contents are within the defined range. And in this picture we can see that how the hyperosmolar blood turns into the isoosmolar blood. So the major act here is that of the ADH by increasing or decreasing reabsorption of water from the urine. The plasma colloidal osmotic pressure or osmotic pressure, which is mainly due to the presence of plasma proteins, sodium, glucose and other solutes, they will stimulate the osmoreceptors. The osmoreceptors will release ADH, and the ADH will act on the kidney, causing reabsorption of water, which will make the urine hyperosmolar while the blood hypoosmolar. Water is moved from the urine into the blood. An additional effect of ADH is on the sweat glands, also known as the sudoriferous glands, and here it will decrease evaporation and loss of water from the body. So this is an additional effect of the ADH by adding water to the blood. The third effect is on the arterioles. ADH causes narrowing or vasoconstriction of the arterioles, and it will increase the blood pressure. If the blood is hypoosmolar, by that we mean that the solute concentration is less and water content is more. So in this case, the hypothalamus will do a reverse of this process by decreasing the ADH secretion, inhibiting the reabsorption of water, and ultimately making the blood isoosmolar. The two abnormalities of the abnormal ADH secretion are the diabetes insipidus, in which there is no secretion or decreased secretion of the antidiuretic hormone, and the second abnormality is the syndrome of inappropriate ADH secretion, in which there is over secretion of the antidiuretic hormone, which increases the reabsorption of water, making the urine hyperosmolar and the blood hypoosmolar. As I mentioned, the second hormone from the posterior pituitary gland is the oxytocin, and it has got mainly its actions in pregnancy on the pregnant uterus and on the mammary glands or breasts in lactating mother. In diabetes insipidus, there is decreased secretion or lack of antidiuretic hormone. And as what happens in diabetes mellitus, in which the glucose or sugar excreted in urine cause polyuria, increased urine, and polydipsia, automatically it will lead to increased thirst. So the same polyuria and polydipsia occurs in diabetes insipidus. But here the problem is not due to increase or decrease concentration of glucose, hyperglycemia or hypoglycemia. Here the problem is with the under secretion of antidiuretic hormone. The two major types of diabetes insipidus are the central diabetes insipidus, in which the hypothalamus is not making or secreting the antidiuretic hormone, and the second one is the nephrogenic diabetes insipidus, in which the ADH secretion from the hypothalamus is normal, but the kidney is unresponsive to the action of antidiuretic hormone. Whatsoever both the conditions will lead to lack of reabsorption of water and will lead to polyuria followed by polydipsia. And in diabetes insipidus, large volumes of dilute urine of low specific gravity with less content of the solutes, hypoosmolar urine is excreted. And what will happen that the loss of water in the urine will increase the osmolality of the blood or plasma. And when there is less water, the sodium content in the plasma will become more concentrated due to less amount of water. And this condition is known as hypernatremia. And it will lead to, in diabetes insipidus, due to lack of ADH, there will be polyuria, increased excretion of dilute urine, and automatically it will lead to stimulation of the thirst center and polydipsia or increased intake of water. The two other types of diabetes insipidus, in addition to the central diabetes insipidus due to lack of ADH secretion from the hypothalamus, or the nephrogenic diabetes insipidus, in which the kidney is unresponsive to the action of ADH. There are two other types. One is known as gestational diabetes insipidus. It occurs in a pregnant female. And here the placenta of some pregnant females produce an enzyme which is known as the vasopressinase. And unfortunately, this production of vasopressinase, the enzyme break down the ADH. And as a result of the breakdown of ADH, no ADH is available and the patient develops diabetes insipidus. And sometimes the condition may remain even after childbirth for some time due to the pre-existing vasopressinase enzyme present in the blood. The fourth type of diabetes insipidus is actually psychogenic polyuria and psychogenic polydipsia. Here there is no organic problem, but in the problem is purely psychological. For example, patients of schizophrenia may compulsory drink large amounts of water, and as a result they will pass large amounts of urine, and these patients also suffer from polydipsia and polyuria, but they have no organic problem. The problem is purely psychological. The symptoms of diabetes insipidus include passing large amounts of dilute urine, hypoosmolar urine, and polydipsia. Drinking automatically polyuria will lead to polydipsia. And sometimes patients of diabetes insipidus may pass up to 3 liters of dilute urine each day. And this loss of water can quickly lead to dehydration, and due to decreased blood volume it can lead to hypotension. As a result, plasma osmolality is increased. There is loss of water, the concentration of solutes increases, and the plasma osmolality is increased, and it can cause fatigue, nausea, vomiting, poor concentration, and confusion due to the effects on the brain and central nervous system. Here this is an isoosmolar plasma. The concentration of solutes and the content of water, they are within defined ranges. But in diabetes insipidus, what happens that there is no antidiuretic hormone and no reabsorption of water from the urine. So the urine becomes hypoosmolar. Large amounts of water are passed as compared to the concentration of the solutes. And as a result of this, what happens that since there is no reabsorption of water, the concentration of solutes in the blood increases and the blood becomes hyperosmolar, increased osmolarity. In this picture we can see that in hypoosmolar solution the solutes are less and the water content is more. And in this picture, the solution is hyperosmolar. The solute concentration is more as compared to the content of water. Now, for making diagnosis of the diabetes insipidus, we listen to the patient, the sign and symptoms, polyuria, polydipsia, effects of increased blood osmolarity on the central nervous system in the form of confusion and fatigue and other effects. We do a very sensitive test known as the water deprivation test, in which we restrict the patient to take water. So, when the patient is not taking water for some time, what happens that in a normal person, when there is normal secretion of antidiuretic hormone, it will increase the reabsorption of water from the urine, and the urine will become hyperosmolar. Water is reabsorbed because the body is deficient in water, and the solute concentration of the urine is increased. But if there is lack of antidiuretic hormone, as happens in central diabetes insipidus due to problems in the hypothalamus, what will happen that there is no reabsorption of water, and the urine is hypoosmolar. Normally it should be hyperosmolar, but since there is no ADH, the urine will become hypoosmolar. The same is the situation is in nephrogenic diabetes mellitus, diabetes insipidus. Because of lacking the action of ADH, there is no reabsorption of water and hypoosmolar urine is passed. While in diphthogenic diabetes insipidus or primary polydipsia, the solute concentration is comparatively not so much changed as compared to the two pathological conditions. Now, what we do that here we administer a synthetic vasopressin known as the desmopressin, having an ADH-like effects. In this person who is normal and whose ADH secretion is normal, and after water deprivation the ADH was secreted, it caused reabsorption of water and it made the urine hyperosmolar. If we give desmopressin, it will cause little change, less than 10% increase in osmolarity. But here in central diabetes insipidus, after water deprivation, there was no change in the urine due to lack of antidiuretic hormone. But when we administered antidiuretic hormone, it increased reabsorption of water from the urine, and the urine became hyperosmolar. Water was reabsorbed by the desmopressin, and the osmolarity of the urine was increased, the solute content was increased, and water decreased. And here the injection of desmopressin will cause increase in urine osmolarity by more than 50% increase, and it will turn to more than 800 milliosmoles per kilogram of the urine. In nephrogenic diabetes mellitus, since ADH was lacking, so there was no increase in osmolality. But here the problem is not due to underproduction of antidiuretic hormone. And when we administered the ADH or desmopressin, it will cause little increase in the osmolality of urine. In dysogenic diabetes mellitus, the problem was psychological and the antidiuretic hormone secretion was normal, and previously it had caused reabsorption of water and increased osmolality of urine. So when we administered desmopressin, it caused little increase, less than 10% increase in the osmolality of the urine. So by using the water deprivation test, we can differentiate a normal person. We can diagnose central diabetes, in which the administration of desmopressin will increase urine osmolality from 300 to more than 800. While in nephrogenic diabetes insipidus, the increase will be less, because as it is unresponsive to ADH, it will be also less responsive to the desmopressin, and there will be little increase in the osmolality. While in dysogenic diabetes insipidus, previously it had normal ADH and it increased the osmolality. So even if we administer desmopressin, it will cause less than 10% increase in the osmolality of the urine, and in this way we can diagnose it.